Hi, this is Scott Sicherer, and I want to thank FAIR and the organizers for giving me this opportunity to discuss the diagnosis and monitoring overview of the topic. And I'm also very pleased to be moderating this session, so thank you again for that. So what would we like to know from our diagnostic tests? It would be wonderful, of course, to have a result that's completely definitive. Do I have this allergy or don't I have this allergy? It would be great to have a test that can determine threshold. How much of the food can I eat before I might expect to have a reaction? Am I sensitive to teeny tiny amounts? It would be great to have a test that could tell severity. If I eat this food, how severe of a reaction or what symptoms might I expect? What about prognosis? A test that would be able to tell me, is this allergy going to go away? And finally, since there are therapies that are available or coming to be available, it'd be great to understand monitoring that would allow us to know if the therapies are working. Our current or common tests are many, and they actually are pretty good. Expert panels have recommended the history and physical examination. A lot of people don't think of that as a test, but finding out what happened to an individual when they ingest the food, what symptoms there were, what was eaten at the time of the meal, those are essential. And I totally expect those to be considered a diagnostic test. It tells us a lot of information. We have prick skin testing. We have allergen-specific IgE. We could have someone stop eating a particular food for a while to see if chronic symptoms go away. And ultimately, we also have an oral food challenge, a feeding test, to know whether the food causes a reaction or not. And I'll talk more about each of those. There are some tests that are out there that are considered by experts to be unproven and experimental, and they're not recommended. Patch testing is considered experimental. That's placing the food on the skin for a day or two and waiting to see if there's a rash that develops. There are intradermal tests, like injecting a little bit into the skin, which are not recommended. And then there are many tests that, again, are considered unproven, like IgG testing for food allergy or muscle strength test, otherwise called kinesiology. There are machines that measure electrical resistance. There's hair analysis and many other things that are not recommended. So why is the diagnosis of food allergy so difficult? Well, let's take a look at this slide. And in the first line, we see someone who's sneezing, and maybe they're exposed to cat. And we could do that skin test. And if it's positive, then we might conclude that, yes, we have a diagnosis of cat allergy, very straightforward. Let's consider someone who got stung by a bee and got very sick with anaphylaxis. Well, we do an allergy test to the insect sting venom, and if it's positive, we could conclude they have venom allergy, insect sting allergy. Now let's consider we have someone who has bad eczema, and maybe there's a suspicion that any of a number of foods that are eaten have caused an allergic reaction. Well, now we're stuck with, if you're testing to a number of foods, you have positive test, positive test, positive test, positive test, a whole bunch of positive tests, and then what's going on, it may not be so clear. So why is the diagnosis a challenge? Well, in food allergy, sometimes there's chronic symptoms. For example, pictured here is the esophagus, the tube that goes from the mouth to the stomach. In someone with eosinophilic esophagitis, inflammation or a rash essentially in the esophagus leads to an illness called eosinophilic esophagitis, or a child who has rashes, eczema. These chronic symptoms may be associated with the foods, but there may not be a direct, immediate relationship, which is very tricky. Also, there are multiple possible triggers. I mean, we eat meals multiple times a day with snacks, and there's a lot of different ingredients. Many different foods may trigger an allergic reaction, so that becomes complicated. There's a lot of different pathophysiologies. For example, we see this child with FPIES, food protein-induced enterocolitis syndrome. It's not the typical immediate type allergy that we call IgE-mediated. It's a different type of pathophysiology. And then there's also this newly described syndrome of alpha-gal, which starts off with being bitten by ticks and then ending up with a delayed allergic reaction to mammalian meats and some other triggers. Definitive outcomes are needed with food allergy, and that makes this a challenge because you might, with environmental allergy, say, well, you might be allergic to dust mite, maybe it's mold, and here's some things to do. But when we're talking about foods, we need to know whether you can eat a particular food or not. And then there are masqueraders of food allergy. This is a picture of a child who has a blushing rash on his face, but this is actually a diagnosis of auriculotemporal or Fry syndrome or a gustatory flushing syndrome. This child gets a red streak on his face from tart foods that make him salivate, and it's a neurologic response. And there's actually no itching or swelling or any danger with that, but it could look like a food allergy. And lastly, as I've already alluded to, the tests that we have are imperfect. Skin test or blood test It may be positive because of cross-reactivity that may or may not be, or it may just be that there's sensitization, meaning a positive test, but you might be able to eat the food anyway. If I go into the park and start testing 100 people for peanut allergy, I'll probably find almost 1 in 10 with a positive test, but clearly not all of those individuals have a peanut allergy. So what is the current algorithm for diagnosing food allergy? This is a complicated figure, which is basically reflecting what the allergist doctor thinks about when they're trying to diagnose food allergy. They think, I'm asking questions about the history. Is this an immediate type reaction? Is it a chronic reaction? Is it an adverse reaction that has nothing to do with allergy? Because you could have food poisoning, or you could have irritable bowel syndrome, or you could have lactose intolerance, a whole bunch of things that make you sick from food, but are not really a food allergy and behave differently. And then once you know what the pathophysiology might be, you start to think, well, what tests am I going to do? Am I going to do the allergy skin test, blood tests? Am I going to take the food away for a while? And so there's basically an algorithm to make the diagnosis that involves a number of different processes. Now, the tests that we think about most right now are the skin tests and the blood tests. And I like to tell patients they're not like a yes-no test, not like a pregnancy test. Rather, it's more like a statistical test. So the stronger the positive skin test, or the higher the food-specific IgE blood level. IgE is the antibody that we're measuring in both of these tests. It's a protein made by the immune system that mediates these allergic reactions. Well, the stronger the response, the more likely there's an allergy, as shown on the graph here, but there's not a definitive. So sometimes you'll have a negative test and still have a situation where you react. Sometimes you'll have a strongly positive test and might be able to tolerate the food, but it's a statistic. And so that's the way that the doctor is putting together the history and the test results to come up with what they think is a reasonable chance of allergy. I think it's 50-50. I think it's 90% you have the allergy, or I think it's only 10% that you have the allergy. This next slide shows the results of a number of studies that are showing cutoff values. At what level of IgE or at what size of skin test does it become quite likely, or 50% likely, depending on how you want to look at it, that there's truly an allergy? I have a black and white picture there with an arrow. Can you see what that is? Well, it's a grain of salt. And the reason I have that there is because all of these numbers have to be taken with a grain of salt. They're not definitive. You might have a higher chance, and some studies say maybe even almost 100% chance of an allergy, but there's always these exceptions. And these studies were done with specific individuals who came into the study at the time. They may or may not have had eczema. They might have been children or older children. And so all these nuances matter. On the next slide, we see what represents an advance in our diagnostics over the past few years, and that's component testing. A food isn't one thing. If I was allergic to you, am I allergic to your eyeball, your heart, your liver? Like, what part of you? So if you're allergic to a peanut, well, there's different proteins in peanut, or so on for other foods. Well, now there are some tests available that look at the antibody response or immune response against specific proteins. This makes a difference because some of the proteins in the foods are more potent or important for the allergic reaction than others. So it's handy to have that additional information. But even with that additional information, whether your body is seeing the potent proteins in the food or those that are less potent, there still are variations. Levels still count. The higher, the more likely there is a reaction. And there are some studies suggesting that this may correlate with severity, and others where it's not so clear. So there's more to be learned about these. It's an advance, but it's not the end of the story. The next slide indicates the severity conundrum. A lot of families really want to know, like, how severe is this allergy? And they assume that the higher the test result, the more severe the allergy probably is. But it doesn't work exactly that way. The immune response is important. So the more robust the immune response, the stronger the response, maybe the more severe the allergy. But it's not the full story, because target organs are part of the story. If you don't have any asthma, you're less likely to wheeze with an allergic reaction or have trouble breathing with it. And you might be at less risk than someone who has significant asthma. The amount eaten matters. The blood test doesn't know, am I eating a lick of peanut or am I eating a peanut butter sandwich? And the more you eat, the more severe the reaction is going to be. The food protein characteristics are important. I have pictured here peanuts and kidney beans. I mean, they're both beans, but way different in terms of their allergic potential, especially roasted peanut. And then there are what I'm calling augmentation factors. There are some things that can happen or that we do that will make a reaction worse than some other day. Exercise is one of those things. So eating a food you're allergic to and then exercising might trigger a reaction Maybe you are more of a reaction. Maybe you don't even have problems with eating a particular food unless you exercise. And the same story could go for alcohol or for aspirin type products, or even for having an illness like a flu. And we're going to probably hear more about that from one of our excellent speakers coming up after me. Prognosis, shown on this next slide, is another thing we'd like to get from our results. And in this particular data that's shown from the Consortium of Food Allergy Research, or COFAR, observational study, we're trying to see what the outcome would be over time for milk allergy. And this slide is showing that it's not just about a blood test level, but in looking at the same time at how severe a child's skin rash, eczema, atopic dermatitis was, their initial milk IG level, their initial skin test level, there were different prognostic factors when combining these. And we could get some idea of how likely it would be that the child would outgrow the food allergy over the coming years, depending on those initial results. But a lot more studies are needed in this area. The next slide shows the oral food challenge, or the feeding test. This is our gold standard test. Really, I call it the proof is in the pudding, literally. Can you eat the food and tolerate it, or do you eat the food and have an allergic reaction? We also learn from this process threshold and to some extent severity, although we stop at the first signs of any symptoms. So we're trying to reduce the chance of a severe reaction when we do this. These are labor intensive, they're time consuming, they're unpleasant if there's allergic reactions. They're a great way to find out what's going on, and we depend upon them. And we usually offer them when we think there's a good chance that it's going to be tolerated. And in research studies, we use these to understand whether a therapy is working or not. But they're unpleasant and would be lovely to have some kind of test that could be done without taking on this time and risk burden. And that's the future of testing. And speaking of the future of testing, I'm so happy to be moderating this session with some amazing speakers who are going to be talking to you about some of the upcoming diagnostics that we have. These future diagnostics, prognostics, and monitoring avenues are really going to change the face of food allergy in the coming years. We're going to hear about basophil activation tests, mast cell activation, cellular responses, looking at different aspects of IgE and IgG responses, and more about components and putting all of this information together. And the future is probably going to be in systems biology and the big data approaches to use as many inputs as possible to come up with the most specific diagnostic, prognostic, predictor of severity and threshold that's possible. And I'm very optimistic about the future and really be able to give a much better picture of what to expect for people with food allergy. So I'm ending there, and I'm looking forward to all of us hearing more from our other speakers in this session, and then having some conversation with them. So thank you for listening.